Medurstand-Understanding Medicine.
I'm Professor Aziz Rehman, and today I'm going to talk about a very serious infection and very unfortunately still very common endemic in our country. In fact, it is becoming more and more problematic because of the resistance that bacteria have acquired, and this condition is called typhoid fever, or simply typhoid, and it is also called enteric fever. Enteric fever implying the involvement of the intestine. Although it is a systemic infection, but the main organ which is affected is intestine, so it is also called enteric fever. So it's a systemic infection. I believe all infections are systemic because there is bacteremia or viremia, but this one is particularly systemic because almost all body organs are affected or may be affected, and it is caused by a gram-negative bacteria called Salmonella. It could come as sporadic cases, and it is endemic in our country. It never actually went away, but it could also come in outbreaks, in epidemics. And if it comes in epidemic, like in many countries of Africa, it could have great impact on public health. There could be lot of mortality, morbidity, and burden on our healthcare facilities. Still very common. Yes, I would say very common because although it may not be as common as simple respiratory infection or influenza or gastroenteritis, but since it is potentially very serious, so it would still be considered common. And very recently we have to deal with multiple drug resistant strains and extended range resistant strains. So I'm going to talk about these situations later. Salmonella typhi, as I said, is a gram-negative bacteria, and it is present only in human. Human is the only source. It is not present in any other animals. So many healthy people, they may be harboring this bacterium in their intestine, and they may be excreting, and they may be source for other people to get the infection. And there are three types: Salmonella typhi, Salmonella paratyphi A and B. Although in the literature it is mentioned the slight differences between these three, but practically speaking, the overall disease pattern is the same. And it doesn't really matter if you are unable to differentiate one from the other because the treatment principles are the same. So transmission and pathogenesis. The first point is somebody who is a healthy carrier, somebody who had suffered from typhoid in the past, and then he recovered or she recovered, but he is passing live Salmonella bacteria into the gut from the bile, and gallbladder may be a reservoir, and this bacterium can make a biofilm on the gallstones or gallbladder polyps, or can survive in gallbladder and excreted in the stool. So if that person is not very particular about the personal hygiene, his hand may be contaminated, and if this person happened to be a food handler and he would contaminate the food, typically food that is served without boiling or heating, any food which is served cold, that is very likely to be infected. It could be some drink, or it could be some fruit, it could be some uncooked food, it could be salads or fruit chart, something like that. So that is ingested by the other person, and this bacterium has developed the ability to survive highly acidic pH of the stomach, as low as 1.5, which is very acidic. This bacterium can pass through the stomach without getting destroyed. In fact, if somebody is on proton pump inhibitors or antacids or some other anti-secretory drugs, his pH may be higher than 1.5, so bacterium would have actually much less difficulty surviving and would go on to the small intestine. And in the small intestine, the last end of the last part of that ileum, it is absorbed. And there are some lymphatic deposits which are visible on the naked eye. They are called Peyer's patches. So this bacterium gets attached to the endothelium, epithelium, and then is absorbed into the Peyer's patches, the lymphatic tissue, and then it is spread through the entire reticuloendothelial system in the body. And the reticuloendothelial system, is present in lymphatic system and in spleen and in liver and in bone marrow. So pretty much everywhere. So all body reticuloendothelial system is infected. Macrophages are affected by this bacterium. And third stage, there is gradual and progressive bacteremia, because there is an incubation period of about 10 days, 15 days. Bacteria is growing and is circulating the body. Patient may not have any symptom or may have very, very subtle non-specific symptoms. And once this bacteremia becomes to a certain level, then they are excreted back into the gut through the bile. So when these bacterium comes to the gut again, so they attach to the Peyer's patches where the bacterium entered for the first time, and there could be still some antigen left there. So there may be antigen-antibody reaction. Antibodies are also present by this time, and antigen-antibody reaction occurs, and there could be perforation, there could be ulceration. So that could lead to the inflammation of the gut and sometime perforation and sometime hemorrhage. So luckily, because of the intervention, these complications are becoming less and less common, but this is the natural course of this disease if not treated properly or if not treated at all. So clinical course, first of all, like any other infection, there is incubation period. Patient has ingested the bacterium and it is going through a certain process of proliferation, bacteremia, antibody formation. These antibodies are responsible for some of the complication, but they're not protective. So incubation period, and then patient develops high grade fever. Now there is a characteristic pattern of fever, and I would describe that in greater detail in a separate slide, but there is high grade continuous fever. And there is a lot of malaise. That means patient feels really unwell, very, very fatigued and tired and anorexic and lack of energy, very, very ill. And since it is a truly systemic infection, as I said, all body organs are affected or can be affected from brain to toe. So there could be any symptom. There could be burning eye, there could be headache, there could be sore throat, there could be nasal bleed, there could be cough, there may be some expectoration, abdominal pain, urinary problems. So you name any symptom. There could be rectal bleeding, melena. So all those symptoms you have heard could occur in untreated advanced typhoid fever. And then there may be recovery. Of course, we don't, these days we almost always give antibiotics, but there could be natural recovery also. So if there is a natural recovery, there may still be some residual symptoms related to gastrointestinal tract and also related to brain. So I think we normally do not, we try to treat patient effectively so that patient recovers completely and there are no residual symptoms. In some cases, if there is no recovery, this disease could definitely be fatal, and it could prove fatal by causing gastrointestinal bleeding or causing perforation, peritonitis, or causing endotoxemia, shock, encephalitis. So there are a number of mechanisms through which this disease can actually prove fatal. So now I'm going to talk about the characteristic of fever as a symptom, and this is important because traditionally the diagnosis of typhoid fever has been clinical. And this is how we have been trained, and I think people, the physician of my age, they would make a clinical diagnosis rather than depending upon labs too much. Of course, we do use laboratory tests also, but I think if you listen to the patient story and if you examine the patient carefully, you would be sure, I think reasonably sure, that you are dealing with a case of typhoid fever. So the pattern of fever is, it is never very abrupt in onset. Like you have seen people who, other infection, they say they were okay at 3 p.m. and then they had just very high spike of fever, and suddenly temperature rose to 103, 104. That is not the typical feature of typhoid. It gradually develops. In fact, first 2 days, patient may just feel malaise, patient just feel unwell. There may not be fever. Patient may just feel little warm. But then in a step ladder pattern, not necessarily very symmetrical step ladder, but gradually fever rises to the maximum, which is 103, 104, and then it becomes chronic, it becomes steady. Of course, there may be some fluctuation, but it usually does not come to the baseline and then goes to spike. So there may be some chills, but not rigors. So this helps you to differentiate between other infections. And initially there are no symptoms. In my earlier slide, I said people with the typhoid could have any symptom. Initially, it is just fever, which is continuous, which becomes higher and higher every day. But there could be just malaise and headache, and maybe abdominal pain, constipation, diarrhea. Later on, there may be gastrointestinal bleeding. So high-grade temperature, which is non-abating, continuous, and was not actually abrupt in onset, and is persisting for 2-3 weeks, and in the absence of other organ-related symptoms, I think that would be highly suggestive of typhoid fever. Of course, you cannot be 100% sure in all the cases, but I think in majority, you can make a reasonably accurate clinical diagnosis. So you need to develop the skill of making a clinical diagnosis, because there may be a situation where you may not have help of laboratory test. So physical examination, the patient looks very unwell, toxic in ill-looking patient, and temperature you will document would be high, 103, 104, unless patient has taken paracetamol or other drug. There may be rose spots. These are not very common actually, and they may be difficult to appreciate in our dark skin, and they may be temporary, and you need to have a very meticulous examination to pick them up. So don't depend on rose spots too much. In fact, if there are skin lesions, with very extensive skin lesions, I would rather think of some other infections like measles or chickenpox. So rose spots may be present. They indicate actually presence of bacteria in the skin, blanching lymph node patches. There may be soft, tender splenomegaly, or there may be occasionally hepatomegaly. There may be tenderness in the right hypochondrium, the region of liver, indicating liver involvement or in a gallbladder involvement, but actual hepatomegaly is not very common, but could be present. Splenomegaly again in relatively advanced disease, maybe in the second or third week of fever, there may be splenomegaly and hepatomegaly. And abdominal tenderness, since it is primarily inflammation of intestine, diffuse abdominal tenderness, particularly in the right iliac fossa and right hypochondrium, is a very important sign. So of course, tenderness is not localized. That would be helpful to differentiate typhoid from acute viral hepatitis, acute cholecystitis, acute pancreatitis, acute appendicitis. There would be diffuse abdominal tenderness, which is a feature of typhoid fever. Now, diagnosis, first of all, clinical. I think, as I said earlier, a clinical diagnosis is possible. At least you should be able to raise a very strong suspicion. Why is that important? Because your subsequent action would be based on your provisional diagnosis. Routine labs, of course, we do CBC in all febrile patients. You won't see much in CBC. There may be little drop in HB, and there may be little leukopenia, and there may be neutrophils are typically not very high in count, because this Salmonella typhi has developed a skill of evading the neutrophils, deceiving neutrophils. So neutrophils do not get to know that there is some foreign bacterium. So that is why neutrophilic leukocytosis is not a typical feature, unless there's a complication like peritonitis. So CBC would be pretty much very unimpressive. It may be useful in fact to rule out other conditions. Like in pneumonia, you would expect very high count. Here in this, there may be nothing much. There may be some increase in monocytes. So LFTs, liver function tests, are almost invariably abnormal. Now, there was a time when we used to use the word typhoid hepatitis. That means we used to consider hepatitis as a complication of typhoid. But these days we consider a liver involvement as part of typhoid, because liver is very rich in reticular endothelial cells. So liver would be almost invariably involved. It would be very unlikely that you would have a case of hepatitis, a case of typhoid with normal ALT. So in typical typhoid, there would be 2 times or maybe 3 times elevation in ALT and AST. But in some cases, there could be much more elevation. There could be actually hyperbilirubinemia. There could be actual jaundice also in some cases. But if there is frank jaundice and frankly abnormal liver function test, you should rather consider viral hepatitis as your primary diagnosis, because viral hepatitis may also cause similar symptoms, and viral hepatitis is pretty much common. In fact, commoner. In my experience, viral hepatitis in our country is commoner than typhoid. Hepatitis A and hepatitis E, they can cause very similar. So we can sometimes judge the level of ALT along with LDH. So I think from that we can make a judgment if it is viral hepatitis or typhoid. A ratio of more than 9 versus 1 is suggestive of viral hepatitis. Blood culture. Now, extremely important. I think if I have to identify one test for typhoid, I would choose blood culture. But there are problems. I think the biggest problem is that in our country, many people, whenever they have any febrile illness, they start antibiotic on their own or on the advice of a family member or a local GP. And often these antibiotics, they interfere with the blood culture. Blood culture, even otherwise, is not positive in all cases. You have to draw 2 or 3 samples. So if somebody is already on antibiotic, then yield of blood culture may be further reduced. So you take a 2 or 3. I don't consider it very safe to discontinue antibiotic for 3 days, which is the recommended approach. If you have to do a blood culture and patient is on an antibiotic, you have to stop antibiotic for at least 3 days and then you draw blood. That sounds little risky. So you could go for bone marrow culture also. Bone marrow culture can remain positive in these patients who have started antibiotic for next 5 days. Although bone marrow culture may be little invasive but very useful if blood culture is not possible. I would take blood culture even if somebody is on antibiotic, but we'll try to get a bone marrow culture also if that is possible. Stool culture may be positive very initially and may be also positive in the later part, but stool culture is mostly used to identify carriers so that their carrier status can be treated and the source can be eliminated. But stool culture in the diagnosis of typhoid fever has got limited value. Then some traditional tests like Vidal test, which tests antibody against H and O antigens of Salmonella, and then little refinement of the same tests, antibody-based tests, IgG and IgM. We could determine the level of IgG and IgM against Salmonella antigen, and we could make a diagnosis. And the point was that if IgM is elevated, it is acute infection. If IgG is elevated, it's a chronic infection. If both are elevated, it is subacute infection. This is a lot of theory behind it, but our experience has shown us, this is a very important statement, our experience has shown us that these antibody tests are more likely to be misleading than helpful. So I think I don't go for these tests anymore. In fact, if somebody comes with this test, I just put the report on the side and go by my clinical judgment. I believe many other physicians have done this, are doing the same. In fact, many laboratories, they have stopped doing this test. So most important test is after clinical judgment is the blood culture. Blood culture is not only diagnostic, but can also give you the pattern of antibiotic resistance. That is very, very important and very, very relevant because we have MDR and XDR strains. Though it takes about 4 days, 5 days, so we would start antibiotic empirically, but then will correct our treatment plan once we receive the report. Complication of untreated typhoid, there could be gut perforation and there could be rectal bleeding because of ulceration, and there could be encephalitis-like condition. Patient may have developed psychosis or seizures or unconsciousness, a meningitis-like condition, or there could be endotoxemia and shock. So a lot of serious complication, they could lead to death. The treatment also includes supportive care. These patients, they require something to lower their temperature and to improve their nutrition and to give them soft and easily digestible food, so that because the gut is inflamed and you don't want to give them very hard food, but at the same time it should be balanced food based on soft diet. And antibiotics, very, very important. Antibiotics are very, very important in typhoid. I'll discuss them in more detail in the next slide. So, role of antibiotics. Number one, it is an absolute must. Now, why am I emphasizing? Because mostly we are using antibiotics when they're not really needed. And mostly we are using inadequate doses and inadequate durations because we're not sure they're needed. But this is a situation where you have to be very, very sure you choose a proper antibiotic and you use them in full dose and for full duration and earlier on. So empirical choice, because the best test is blood culture, that takes about 4 or 5 days. So you would start with empirical choice. Empirical choice is based on your judgment. You know what kind of bacteria is likely and what antibiotic is likely to be effective under the circumstances. You need to know the culture sensitivity pattern in that locality. So full dose and duration, like 10 days or 4 days after defervescence, whichever is longer. That is the typical duration, not 5 days that we use in respiratory infections or in urinary tract infections. So antibiotic has to be 10 days or 4 days after defervescence. Defervescence means when there is no fever without the use of paracetamol, and whichever is longer. So it could be 10 days or longer. Combination, these days, at least that is a trend, at least in our country, we can't really rely on single antibiotic because bacteria has become very, very resistant. So we usually give combination. And then intravenous is best if patient has presented late. If patient has presented early and you have been able to make an early diagnosis, then oral antibiotic may be effective. But sometimes you have to resort to intravenous antibiotic for 2 reasons. One, you want to give immediate and more effective cover by intravenous drug administration. 2, the antibiotic which is going to be effective is only available in injection form. So that is why we have to sometimes start with the intravenous followed by oral. So that brings me to this very important concept. In, I think, 2016, there was a survey done in Pakistan, in the Karachi city of Pakistan, and this was in the news media also, the BBC and other media, that in Pakistan, there is a lot of XDR, Now let me start with this one, multi-drug resistant strain. As the name says, the germs have, the Salmonella has developed resistant to multiple drugs, multiple antibiotics, which used to be effective previously. Like we used to treat these patients with trimethoprim sulfamethoxazole combination, or ampicillin, or ciprofloxacin, or chloramphenicol. When bacteria have become resistant to all these, it is called multiple drug resistant strain. So when this situation developed, we still had some antibiotic, but then came this another phase, extended drug resistant strain, that is XDRs. So when bacteria become resistant to all these, plus third generation cephalosporin. So third generation cephalosporin was once a very, very effective tool. So if bacteria have become resistant to that, then it is XDR, extended drug resistant strain. So the sensitive, currently these bacteria are sensitive to only carbapenems, which are very, very expensive and to be given 3 times. These are basically reserved antibiotics used for some severe infection, but we have to use them for typhoid, and azithromycin, which is primarily a respiratory antibiotic, but that is also helpful. But I somehow never use azithromycin monotherapy. I use azithromycin always in combination with either carbapenem or in MDR cases ceftriaxone. And then there's another class of antibiotic which are related to tetracycline, tigecycline. This can also be used. So MDR, XDR has become very, very common, and there is a very serious risk these may become more generalized and more prevalent. So I think we will then be very, very short of other antibiotic choices. So we need to be very selective. Whenever you have a case of typhoid fever, you treat him or her the way that the infection is clearly eradicated and that patient does not remain a source of further infection to other people. So empirical therapy, waiting blood culture, we would start empirical therapy in case of MDR. I think my choice would be ceftriaxone 2 gram intravenous once daily, as infusion is a small infusion. 2 grams can be mixed in 100 ml saline and can be infused over a period of maybe 30 minutes. And this could be convenient. Patient can go to the hospital or healthcare facility, have the injection and come home. And it is to be for 10 to 15 days, or this, as I said earlier, 10 to 50 days or plus 4 days, whichever is longer. So azithromycin added, is to be added, azithromycin 500 milligram BID for first 5 days. This could, I believe, be replaced by injectable azithromycin also, but injectable is more expensive. So oral azithromycin and injectable ceftriaxone would make a good choice. This is more convenient. So waiting blood culture, you may start with this MDR regimen because this is more convenient. But if this turned out to be XDR, then you would probably be, then you should give meropenem, which is 1 gram intravenous thrice a day. So patient would require hospitalization for 3 times injection or will have to make some arrangement at home, plus azithromycin. So either way, azithromycin is to be given as an added therapy, and primary therapy could be ceftriaxone or meropenem. So the treatment is not only difficult, it requires hospitalization and it also becomes very, very expensive. I think this regimen for 10 days would cost maybe 50,000 rupees, maybe around that figure. So it's very, very expensive for most people. Corticosteroids, dexamethasone. Luckily, these days we do not allow these patients to go into that phase where there is involvement of the brain because of the availability of antibiotic and awareness of. But historically, some people, they used to develop meningitis or encephalitis, and there was a trial, especially in children, that if you use dexamethasone, the mortality related to encephalitis, meningitis can be reduced significantly. But the dosage used is very high. It is 3 milligram per kg body weight. and for the first 24 hours, and then it's brought down to 1 milligram per kg body weight given for 3 days. But you have to be sure that you're dealing with typhoid. I mean, you have to rule out tuberculous meningitis or other meningitis by doing CSF examination. Prognosis, a potentially fatal disease, but early and effective use of antibiotics is life-saving. So do your part well, use effective antibiotic and educate the patient why it is important to take antibiotic for full duration. Prevention, it is a preventable disease. I think first thing is the previous infection does not give you protection. Like in many conditions, a previous infection would give you protection, but in case of typhoid, there is no protection because the antibodies, they are not protected. Public health measures and personal hygiene. This is very, very important. All the population has the right to get clean drinking water and hygienic food, but personal hygiene is also important. When you eat outside, you be very careful that you eat what is freshly cooked, and I think what is served cold like salad, they should be best avoided. Conventional vaccines are given intramuscularly or orally, and they were never very effective, up to 50% protection and not very, very robust and temporary for 2 years. They were to be repeated. So they never became popular in endemic areas. They were popular only in areas like people coming from west visiting this Indo-Pak area or Africa where this infection is common. They would take an injection or oral vaccine and hope that they will be protected. But these new vaccines, the conjugate vaccines, Salmonella polysaccharide attached with the tetanus toxoid, and this could confer immunity, I think in about 90% and much more long lasting. But the production of this vaccine so far is limited. It is produced in India and it is exported to the rest of the world, and so far the supply is limited. Identification and eradication of source. This would be very important, but I believe very, very challenging. Now, this means you have to identify healthy people, particularly those who are handling foods. In restaurants and in hotels, I think there should be a law that every person who cooks food or handles food, serves food, should have their stool examined, cultured, and if they have Salmonella, they should have a treatment for eradication, which could be a prolonged antibiotic usage or sometimes surgery like cholecystectomy. So I think I don't really think anybody would be willing to undergo cholecystectomy just to protect others from getting this infection. I wish that was possible, but I really doubt that people would be willing to undergo this operation, especially when they have to pay from their pocket. I think community service should do this. Recurrence is possible, and if that happens, usually the illness is relatively less severe and it is treated on the same line. And usually recurrence is within 6 or 7 days, but it could occur later also, about several weeks and even sometimes months later. Surgery, there is no much role, at least with the time the role of surgery is now becoming less and less. There could be gut perforation, peritonitis, and that is the place where surgery comes in. But since intestine is very, very friable, and surgeon would typically go for a very conservative approach, just stitch the perforated part and put a drain and do the conservative treatment rather than extensive resection of the gut. So that brings me to the summary of this very, very important lecture. First of all, you need to keep a high index of suspicion if somebody comes with continuous fever, high-grade fever, in the absence of dominant organ-related symptoms, and patient looks very, very unwell. And if there is a family history of typhoid, I think, that is very important. And worst thing to do is inadequate antibiotic. Unfortunately, we start antibiotic in subtherapeutic doses and we stop them also prematurely. So start antibiotic, the proper dose, proper choice of antibiotic, full dose, and continue it for 10 days or 5 days after patient become afebrile. Then blood culture is diagnostic but has got limitations. So that is why you have to start empirical therapy, and you need to know what empirical therapy is effective in your community. So as I said, if you do MDR, ceftriaxone and azithromycin, and once you receive the report and it turned out to be XDR, then meropenem and azithromycin. If for some reason you have this suspicion of XDR because a contact with that person had XDR, then you might as well start with XDR regimen, meropenem and azithromycin. Prognosis is good with effective and early antibiotic, but it is very, very bad if antibiotics are not given. So impact of new vaccine is still to be seen because of its limited availability. But I think even if vaccine is available, I still feel the best thing to do is to look after your personal hygiene and to improve the drinking water and food in our communities. Public health measures and sensitive eating behavior is the best preventive strategy. Thank you very much. I hope you learned something new in this lecture. I think it is very, very relevant, and in our society you have to be expert on treating typhoid because it's very, very common and it could become serious and fatal. Thank you, Professor Aziz Rehman from Medurstand. I really look forward to see you in my next lecture on some other important topic. Thank you.